Okay.
Distinguished guests, honorable speakers, ladies and gentlemen, we welcome you to join the 2024 China-Europe Anti-Cancer Summit and the Latin American Global Cancer Week. My name is Yihai Cao, and I'm a professor specializing in cancer research at the Karolinska Institute, Stockholm, Sweden. It's my great honor and pleasure to host this summit, which is organized by the China Anti-Cancer Association, abbreviation is called CACA, the Latin American and the Caribbean Society for Medical Oncology, SLACOM, and eChinaHealth. We thank all organizers for their tremendous efforts to organize this important conference. Today, we have invited 3 leading experts from both China and Europe to discuss the latest breakthroughs in cancer research and clinical management. Our panel includes the president of CACA, the president European Cancer Organization, and myself. Today's program includes 3 sections. The first section is the welcome remarks by the Vice President of CACA, the keynote lectures, and the panel discussion. So let's start the first section, welcome remarks. It is my great honor and pleasure to invite Professor Ying Wang, the Vice President of China Anti-Cancer Association, CACA, to deliver the welcome remarks. Professor Wang is the Vice President of CACA and serves as the General Secretary of the Asian Oncology Society. Since joining the board of directors in 1997, she has played a central role in the China Anti-Cancer Association. Under her and others' leadership, CACA has achieved significant milestones in cancer care and research. So, Professor Wang, please, can you deliver your welcome remarks?
Okay. Thank you, Professor Cao's introduction. Dear distinguished guests, ladies and gentlemen, good evening, good morning, and good afternoon. It's my privilege to give a welcome speech at the opening ceremony of the 2024 China-Europe Anti-Cancer Summit. First, on behalf of Professor Daiming Fan, President of the China Anti-Cancer Association, I would like to extend my warm welcome and sincere thanks to all of you. Second, I would like to thank invited speakers from European Cancer Organization and the Karolinska Institute. Thanks for your great support and contribution. Also, I would like to thank eChinaHealth for your cooperation to make this event happen. Last year, we successfully hosted the first China-Europe Anti-Cancer Summit in May. The event attracted 12.5 million audiences online from 20 countries. Meanwhile, we also held another 9 bilateral anti-cancer summits with US, Canada, Australia, Latin America, Africa, and Singapore. The viewers online in total are over 113 million across 35 countries in the world. Today, we're pleased to launch the second China-Europe Anti-Cancer Summit. I believe this event will provide us a good opportunity for better understanding the cancer burden in China and Europe, and enable us to work together to find an effective way for cancer control. Meanwhile, I believe this summit will facilitate mutual collaboration between China and Europe in the future. Besides, this summit is also one of the activities of Latin America or a Global Cancer Week, which launched by Latin American and the Caribbean Society of Medical Oncology. Professor Kazap, the founder of SLACOM, is also presented here. So we are pleased that this webinar will not only attract the audience from China and Europe, but also from Latin American countries. Hopefully, this summit will attract more and more audiences and promote global cancer care in the future. Thank you.
Thank you, Professor Wang, for your warm welcome remarks. We now move to the key lecture section. First, let us welcome our distinguished speaker, Professor Daming Fan, the president of CACA. Professor Fan is a member of the Chinese Academy of Engineering and an international member of the United States and French National Academy of Medicine. Professor Fan specializes in both clinical and basic research of digestive diseases. His work has been recognized by receiving numerous prestigious awards and prizes. He has authored over 200 books. These are professional books. Published over 700 peer-reviewed research articles, including leading international journals, and serves as the editor for 15 international medical journals. His extensive contributions have significantly advanced medical science and patient care. So the title of his lecture today is Development of Holistic Integrative Management of Cancer in China. Professor Fan, please.
Dear Mr. Chairman, Professor Chao, dear my colleagues, Professor Degi, Professor Kazak, Professor Wang Yin. Good evening or good morning. I'm Daming Fan, the president of CACA. I'm very pleased to participate in this very important international conference to share our latest contribution on holistic integrative management of cancer in China. As you know, China bears heavy cancer burden. According to the statistics, about 1 out of 4 cancer patients in the world is from China. About 1 out of 3 patients died of cancer is from China. There are about 8,000 patients died of cancer every day. While the 5-year survival rate of cancer patients in Europe is about 70%, it is almost 40% in China. Standard diagnosis and appropriate treatment is the key to improve overall outcome of cancer. Therefore, guidelines play an important role in cancer prevention and treatment. As everybody knows, one cannot completely copy the guidelines from other countries. Tailoring the guidelines to meet the need in different countries is essential due to different diseases, etiologies, and population characteristics. For example, liver cancer ranks the second cause of death in China. Its main etiology in Europe is HCV, while in China, it is mainly caused by HBV. Hepatitis, as you know, is curable with antivirus therapy. So the HCV-induced liver cancer is theoretically curable. However, it is difficult to cure the hepatitis B. Hence, the key to treat hepatitis-induced liver cancer lies in etiology. As for the esophageal cancer, which ranks the fourth in China, it is mainly esophageal squamous cell carcinoma, ESCC, in China. But in Europe, it is mainly esophageal adenocarcinoma, EAC. In China, it is mostly related to the dietary habit, for example, consuming too much nitrate, while in Europe, it is mostly caused by reflux disease. Therefore, in China, we cannot adopt the guidelines for EAC treatment. Due to the current situation of balanced medical resources and non-standard cancer care in China, it is necessary to develop guidelines on cancer management that adhere to the concept of whole pulse holistic integrative management and operable in clinic with accessibility at the grassroots level. From 2022 to 2023, CACA organized over 13,000 leading experts to develop the CACA guidelines for holistic integrative management of cancer. The guideline contains more than 10 million Chinese characters and was translated into 16 languages, with the 46,500 continuing medical education CME questions and answers. It covers 113 topics, including 53 types of tumor and 60 techniques, which encompass the 97% of Chinese tumor patients. Adapting previous guidelines, but emphasizing the uniqueness of Chinese physicians, it becomes a standardized guideline system with both Chinese characteristics and international perspective. China's attitude towards cancer may be complementary with Europe. We advocate the concept of holistic integrative medicine and emphasizing a multidisciplinary treatment, MDT, to holistic integrative management, HIM, which means to establish a multidisciplinary working model to formulate an individualized and integrated healthcare plan and to achieve optimal effect using the holistic view and integrative regimens. This is the great amount of essence in traditional Chinese medicine, TCM, that we cannot forget. For example, we found the arsenic trioxide, which was caused in TCM 2,000 years ago, can treat acute promyelocytic leukemia, APL, with great effect. Another example is antimethicillin. It is extracted from plants and can be used to treat malaria. And Mrs. UU2 has won the Nobel Prize because of it. Now, it is found that antimethicillin can reverse not only the bacterial drug resistance, but also the tumor cell drug resistance. Besides, TCM indicated 2,000 years ago that microbiome can treat disease. If chemotherapy doesn't work for tumor and then multiple drug resistance occurs, we don't need to deal with tumor cells. We just need to change the intestinal microbiota that the drug resistance of tumor cells can be reversed Thus, our guideline has integrated TCM with a Western medicine. The foreign guidelines emphasize more on diagnosis and treatment, but ours are different. As I mentioned before, CACA guidelines focuses on the whole process of prevention, screening, diagnosis, treatment, and rehabilitation. As you know, 1/3 of the tumor can be prevented by changing lifestyle. I am a gastroenterologist. Most of the time, more than 260 endoscopic procedures were performed in my department per day, but most of the endoscopic screening for cancer are negative. We need to perform tens of millions of endoscopic screening for cancer in China. If we stratify and focus on the high-risk population, we will get more efficient results. Also, the follow-up for rehabilitation is very important after the treatment for cancer patients. Doctors need to conduct a follow-up and provide guidelines for patients very closely. For example, patients with lung cancer, which is caused by smoking, should stop smoking after treatment and change their lifestyle. CACA technique guidelines for holistic integrative management of cancer focuses on the technique and how to choose the appropriate treatment for different patients with emphasis on assessment, support, control, protection, and survival. First is assessment. We should assess the patients before receiving the surgery or other treatment. In China, around 50% of cancer patients are anemic, but 92.8% of them directly undergo surgery or other treatment without treating anemia. 70% of the patients are malnourished, and 70% of them directly undergo surgery or other treatment. We should treat the cancer patient rather than the patient's cancer. Thus, we need to perform whole body assessment for patients in the future. Second is support. After the assessment, we need to complement the insufficiency such as nutrition and psychological to make the patient be strong enough to undergo the surgery or other treatment. Third is control. We should control the growth of a tumor cell rather than just kill them, because everyone has tumor cells in their body, and they will only become cancer when growing into a certain amount. If we kill the tumor cell, the normal cell will also be killed. Hence, many cancer patients die faster once get treated. The fourth is protection, which means to protect the normal organ. A large proportion of cancer patients die from the damage of normal organ functions, such as the damage of a liver caused by hypocalcemia due to the cancer or treatment of cancer. All kinds of treatment do harm to normal organ functions. Surgery is a mechanical damage. Chemotherapy is a chemical damage. Radiotherapy is a physical damage. Biotherapy is a biological damage. There is also the psychological damage. Cancer patients are weak, and it will cause problem if we don't protect them. We have specially developed 15 guidelines on normal organ protection. Lastly is survival. The prognostic effect doesn't only refer to the removal or the reduced size of tumor, and they are just surrogate endpoints. The primary endpoints should refer to prolonging the survival time and improving the quality of life. These two indicators can be used to evaluate which therapy and which doctor is better. The patient may die even if the tumor is cut out, and this is not the effect we hope to achieve only. In the past 2 years, we have released and promoted the CACA guideline nationwide. We have held 100 sessions not only to doctors, but also to the public, with a total of more than 2.6 billion online visits. We also launched a flagship English journal named Holistic Integrative Oncology. It is an open access, peer-reviewed journal on all aspects of oncology research. Its editorial board comprises over 100 world-leading experts. We welcome more renowned experts to join us. HIO publishes guidelines, complementary research and review, and it is free of charge for authors. The last November, we heard the 2023 Chinese Congress on Holistic Integrative Oncology, CCHIO. It is a significant platform to promote the concept of a holistic integrative management of cancer, as well as the CACA guidelines. The main Congress venue was in Tianjin, and there were the 32 venues across the whole China. Altogether, we heard 218 sessions. The Congress brought together the 4,862 national and international speakers, and attracted 165,000 participants in total. Over 100 experts from different countries and regions attended the 2023 CCHIO. During the Congress, we heard the 4 international sessions, which attracted over 16.9 million online visits. This year, CACA will hold 2024 CCHIO in conjunction with the 4th International Congress of Asia Oncology Society, LS 2024, from November 15th to 17th in Xi'an, China. During the Congress, CACA will host the joint sessions in collaboration with 10 renowned journals, including Nature, Science, Cell, JAMA, Lancet, New England Journal of Medicine, British Medical Journal, Journal Clinical Oncology, Cancer Cell, and Cancer Research. We also plan to host joint sessions with 10 international organizations, including UICC, SPCC, Cancer Australia, SLACOM, ASCO, AACR, ACS, NCCN, ISMO, and EACR, the European Association for Cancer Research. We believe that the sessions will make this Congress a truly meaningful experience for all participants. Through a series of strategic steps, CACA has laid the groundwork for the development of holistic oncology in China. However, we know that this is just the beginning. As we all know, the issue of cancer bears on the warfare of people of all human in all countries, and the health of humanity. Eliminating cancer should be the common pursuit of all mankind. Recognize this, CACA has taken about sleep by establishing WHO, the World Association for Integrative Oncology. The aim is to break the bottleneck in the development of oncology and innovate a new system of holistic integrative oncology. We have been learning from foreign guidelines and got benefits. However, the MDT to heme model in CACA guideline may reversely benefit to other countries. The 5-year survival rate in foreign countries is 70%. By adopting foreign guidelines previously, the rate in China has reached 40%. However, the CACA guidelines will help us improve for the rest 60% and may provide references for the foreign countries to solve their rest 30%. So that is my talk. So thank you very much thank you for your attention.
Thank you, Professor Fan, for your inspiring lecture of a holistic view of oncology. We tremendously appreciate that you share your integrative knowledge and the vision with us. So now we move to the next speaker, Professor Saba Deji. Let's welcome the Professor Saba Deji, the President of European Cancer Organization. The short name is ECO, to give his keynote lecture. Professor Deji is a full professor with rehabilitation and a researcher at the Babis Bolyai University, Romania. He is a licensed principal social worker with a private practice. Dr. Deji earned his bachelor and master degrees in social work, as well as his PhD in medical psychology. He holds the distinction of being the first ombudsman at the Barbis International Psycho-Oncology Society and the former member of the board of directors. The title of his talk today is the status and the challenges of cancer prevention and control in Europe. So Professor Deji, please.
Thank you very much, Professor Cao. I think it's such a wonderful moment and day for us to meet again. It's the second summit that we are doing together in partnership with the European Cancer Organization. And I was very much impressed by Professor Fan's speech, and especially about the international outlook that he laid out in his speech. So maybe we will have the chance to talk about a little bit later on. But for the moment, I am more than happy and delighted to have a quite detailed presentation of where we are at the moment in cancer prevention and cancer control in Europe. At the moment, I am a president of the European Cancer Organization, and I am also affiliated with the International Psycho-Oncology Society. As you have heard in the introduction, which I kindly thank Professor Cao, my background is in psychosocial oncology. So quality of life actually and survivorship means a lot to me and to our mission. And may I share a very small secret with you? As I was listening to Professor Fan, I made a note in my notebook because Professor, you said we should treat the cancer patient rather than the cancer of the patient. And this is so close to my professional heart, because patient-centered quality cancer care is something that I think we are all striving for across the globe, and we try to do the best we have for the patient and for those who are together with the patient, most of the time the family members. So that quote from your presentation, it's really something that I will take with me. I will start with, of course, a short resume of what the talk is going to be about today. I would start by saying a few words about the European Cancer Organization. And also, I will share with you some statistics from Europe and actions that are happening on the European level, but also on the level of the national countries in Europe. And of course, always it's very helpful when we share this kind of summit passion to talk about the future and what is going to happen in cancer prevention and control in the near future and a little bit more ahead. And I'm going to finish with the prospects of increased collaboration between the continents, including Europe and China and Latin America, and of course, all other continents who are working for cancer control and prevention. So let me say a few words about our organization, which is the European Cancer Organization here in Brussels. We have 42 member societies and 21 patient advocacy groups. And we are one of the biggest cancer organizations now in Brussels. And our mission is to work together. This is the most important thing, to work together and to build consensus and achieve improvement in cancer care across Europe and beyond Europe. Mainly, our work is focused on reducing the burden of cancer, improving the outcomes, and of course, as I just mentioned, quality of life and survivorship planning, and also implementation. It's very, very important to us. And we are doing all this through multidisciplinarity and multi-professionalism. I think these are the values of cancer care all across the globe, because without multidisciplinarity and multi-professionalism, you just cannot get to the patient-centered care that is so much needed nowadays. Here you can see some of our member societies. I think some of them are quite very familiar to you. And these are very important also together with the heart of the European Cancer Organization, the patient advocates. And as we heard before, we have 21 patient advocacy groups, and they are involved in policymaking activities. And of course, as I said, being the heart of the European Cancer Organization also means that they are highly present and involved in all the focus topic networks that we have. At the European Cancer Organization, at the moment, we have 10 focus topic networks. And of course, one of them is related to survivorship and quality of life. So we are doing this together, professionals and patients and policymakers alike. As I mentioned, we have 10 focus topic networks. It starts with prevention, early detection, and screening network. And I heard in your presentation, Professor Fan, the HPV and all the virus-related cancers. We also have a very special action network on this. We have the health systems and treatment optimization network. We have the quality cancer care network. And again, the survivorship and quality of life network. We have the digital health network. We have the inequalities network. And one of the hottest network now, it's the workforce network, as we are facing a workforce crisis in oncology, not just in Europe, but maybe in some of the continents of the world. And probably this is one of the things that we can also share in our priorities. And we, of course, had this very special network on the impact of COVID and cancer, which now it's merging together with the crisis network, so it gets a new name. And also we have a very special ECO and ASCO network, which started during the war in Ukraine, and it continues, and we are going to actually meet very soon. We just finished an absolutely fantastic Euro-American summit in Dublin a few weeks ago. And we're going to continue as usually at the ASCO meeting in Chicago this year. So Professor Fan mentioned, outreaching to ASCO and working together with all these important professional oncology societies across the globe. So these are the focus topic networks that we are working together. And on the side of the cancer patients' rights, in Europe, there is a European Code of Cancer Practice in which we laid out what are the rights of the cancer patients. Again, you will see a list of 10 rights of cancer patients, and this code is meant to be a practice instrument in Europe. So we are pushing very hard for this one. So equal access, access to information, quality, expertise, and outcomes, specialized multidisciplinary care, shared decision-making with the patient, research and innovation, quality of life, integrated supportive and palliative care, survivorship and rehabilitation, and reintegration, which of course includes return to work as well. So this is the code of cancer practice that is very dear to the European Cancer Organization. And this is across Europe a kind of empowerment to have the rights of cancer patients enacted. Let me tell you a few words about the cancer challenge, or maybe I would use the word burden in Europe. So in 2020, we had 2.7 million people in the EU which were diagnosed with cancer, and an estimated 1.3 million people lost their lives due to a cancer diagnosis. As you know, today, Europe is accounting a tenth of the world's population, but this is very important, a quarter of the world's cancer cases. So it's quite a burden, quite a challenge. And lives lost to cancer in EU is going to increase. And as we estimate in 10 years by now, it's going to increase about 24%, making it the leading cause of death in the EU, which is at the moment the cardiovascular diseases. So in policy, that also means a very important economic impact. So the overall economic impact in Europe of this increase is expected to exceed 1 billion annually euros, which is quite a burden, a financial burden. I will show you one slide on the incidence and one slide on the mortality. Here you can see a breakdown of these cases according to genders and according to the size of the cancers that are most common. And you will see here that there is a slight gender imbalance between men and women in cancer. And also you can see that, for example, colorectal, it's one of the shared burdens in men and women on cancer. And of course, in women, the highest cancer incidence is on breast. In men, it's on prostate cancer. And I think this is statistical perspective that it's quite comparable with other countries and regions. And here again, you will see on mortality based by gender, and also you will see the standardized rates of cancer mortality based on the countries of the EU. We also have, of course, included the United Kingdom. And here you can see that the burden of cancer mortality is quite high. It's actually 12% for both men and women in the EU. And you can see that one of the lowest cancer mortality rates in EU, it's on Cyprus, Finland, Malta, Sweden. And the highest burden countries are Hungary, for example. We can certainly see growing incidence and also a growing mortality. But with this one also, we have to see the balance, and we have to see that also there is a growing survivorship group of citizens, of people who were affected by cancer, who have a history of cancer. And this number now, it's up 20 millions of cancer survivors. It's estimated that now it's around 22 millions of people who had a history of cancer in Europe, which is around 4.2% of the total population in EU. And according to the gender criteria, you will see that there is a skew towards the female gender. So 55% of the survivors, which is a growing group here in Europe, is actually it's made up of women. And also that 70% of the cancer survivors are people aged 75 and beyond that. So the increase was quite obvious and quite hopeful. So if we compare 2010 and 2020, you will see that it was an increase of 45% in cancer survivorship in Europe. And I would like to highlight here that 35% of them are long-term survivors, meaning that they are beyond the 5-year. They are mostly 10 years and plus in their survivorship or history or after the history of their cancer diagnosis. So yes, we have incidence growing, we have mortality growing, but also we have survivorship growing. And I think that we need to maintain this balanced view when we are talking about cancer policy. And cancer policy is really at the heart of the European Cancer Organization, and promoting a vision of what Europeans and Europe can achieve on cancer together really for us has been a journey to realization. Here you can see on the left of your screen, well, our old ECO newsletter, where it certainly, we already envisioned a bold vision of a sort of fight against cancer in Europe. And let me tell you that brought on the European Master Plan that for the first time meant that we joined forces to fight against cancer in Europe. So 2019 was the first time when we saw a commitment to that vision that we shared at ECO and ECHO back in the time from the top level of the EU. Here you can see, of course, Commissioner Kyriakides, cancer survivor herself, who is a health commissioner of the European Union. And of course, she is the leading figure of the Europe's Beating Cancer Plan. And also you can see Ursula von der Leyen with a wonderful support for Europe's Beating Cancer Plan. So 2019 was a moment in time for us. And then, of course, the European Cancer Organization continued to speak as one on the level of the European Union. And we had many reports, all of them you will see, and you can read them and download them freely on our website. So we have the report, which is called Free from Cancer, Achieving Quality of Life for All Cancer Survivors and Patients. And then we have another report, which was made together with OECD, Comprehensive Cancer Care Across the EU, which was a sort of a position paper on advancing the comprehensive cancer care in the European Union. And very important, another report on giving the professionals the right tool for working against cancer. And then in February 2021, we had the Europe's Beating Cancer Plan published and officially launched. And again here, the European Commission's President, Ursula von der Leyen, and Commissioner Kyriakides were very much involved. And it was not just a piece of paper. It actually was a plan which had a quite generous budget of 4 billion euros. And cancer, for the first time, and action against cancer was included in all the programs and goals that the EU had, including the EU for Health program, Horizon Europe, which is based on innovation and research, and the Digital Europe program as well. So 2021 really meant a milestone for Europe's Beating Cancer Plan. what are the key goals of the Europe's Beating Cancer Plan? But first of all, we want to do everything that's possible to eliminate cancers that are caused by viruses. Of course, the most well-known is HPV, the human papilloma virus, but also we talk about here about liver cancers caused by viruses. Then we have the tobacco-free generation, which is very much in the Europe's Beating Cancer Plan, which means that by 2040, less than 5% of the population uses tobacco, which is around 25 at the moment, 25%. And then cancer screening. We know that if we want to catch cancer early, and Professor Fan just said, yes, we all have cancer cells in our body, but there is a point when you have to beat it, right? And this point can be very much helped if we are doing the screening. So we want to ensure that 90% of the EU population qualify for breast, cervical, colorectal cancer screenings, and these are offered quite quickly by 2025 in all European countries. And as I mentioned before, the comprehensive cancer centers, we want to ensure that Europe's population, 90% at least of them, has access to a comprehensive cancer center in their country, in their national service by 2030. So I will not read this one, but here you can see the Europe's Beating Cancer Plan's flagship initiatives for 2021 to 2025. And you can see the 4 pillars here. So there is the pillar of prevention, early detection, diagnosis and treatment, and quality of life and survivorship. So this is the road that we are walking on now in Europe on the topic of cancer prevention and control. And of course, as I said, it was quite a nice budget that was given together with the Europe's Beating Cancer Plan. So that means that the plan is coming alive through many innovative and very interesting projects. Some of them are coordinated by the European Cancer Organization, and some of them are, of course, done in partnership with us. Here you can see some of them, like Interact Europe or Smart Care. And of course, the plan comes alive through legislation. I will be very short. Legislation on asbestos-free future or the European Green Deal. You know that climate change is getting more and more part of the quality cancer care, so we need to discuss this more and more. And also the plan is coming alive to national visits all across the Europe. As you have seen, there is so many country-specific cancer incidence, mortality, and survivorship data. And our work is to be there on the country level and try to do an implementation and action on cancer screening and eliminating HPV on the country level. Here you can see also the Atlas of HPV prevention that was launched in June 2023. And it's again for all this European level. Another topic which is very, very important now, and it's part of the right, part of the Europe's Beating Cancer Plan, is the right to be forgotten, which means that we want to make sure that cancer survivors, people who have a history of cancer, are not facing financial discrimination. So the right to be forgotten means for cancer patients that we want to ensure that they can have financial services and insurance services 5 years after confirmation of remission. Insurance providers should no longer take individuals' cancer history into account. I have to tell you that from the 27 EU countries, now we have 12, not 9, 12 countries which have a regulation or a legislation on the right to be forgotten. And we are full speed ahead because we want that the other 12 countries, that 15 countries that don't have right to be forgotten legislation at the moment, to have it as well. So to make sure that things are going fast and in the right direction, we launched the Time to Accelerate Together Against Action manifesto last year at our summit here in Brussels. And we have more than 100 endorsements. And of course, as the elections are coming very soon on the 9th of June here in the EU, we are inviting all candidates standing for election for the European Parliament to give their support to the time to accelerate vision. So that's very important for us. Here you can see our recommendations from the Time to Accelerate manifesto about all this prevention and all this cancer control topics like tobacco sales that should be at the minimum of age of 21. Also, secondhand smokes indoors and outdoors, very important. And also bringing a taxation for the new kind of smoking devices and products that are very much emerging. And of course, the nutritional labeling for foods using a color-coded scheme, for example. And that's also a very sensitive topic, having this kind of health warning labels on the alcohol as well, not just on the tobacco products. Sunbeds also needs to be regulated as medical devices, as we know that sunbeds, they do have a risk of cancer. And also we included in our manifesto other carcinogen materials that usually are in the workplace and should be regulated as well. So as you see, there are a lot of recommendations in our Time to Accelerate manifesto for early detection, for prevention, and for control of cancer, especially through screening implementation projects. If I could, in one slide, summarize what is the Time to Accelerate beyond the national country visits and beyond having this very clear message that the Europe's health workforce is in crisis. And if we want to accelerate in cancer care, we need to take a look and to change, and we need to do it together. So besides all this and what you have heard about the Time to Accelerate manifesto, I would say one slide coming back that Europe's Beating Cancer Plan was the first step, and this was an excellently completed step. But at this moment in 2024, going on to 2025, we need a refresh. The plan needs new developments because the science of cancer also developed, and we need to expand the European goals on cancer control. So, as I mentioned, we are seeking synergies with global partners, like we had the joint Euro-American Forum that I mentioned, so with America, and of course, with you in China. So we would love to establish new partnership and broaden our established partnerships. As my organization, our organization, the European Cancer Organization, just launched a new international committee. You will have it on our website. And so the role of the International Committee of ECO is to do this, to expand and broaden our international partnership. And I think, and I will end with this, cancer is a universal challenge for all countries, for all continents, and for all health systems. Today, I had the chance, and I am very thankful to present what is in Europe, what is happening, where we are now in Europe. But again, ECHO, the European Cancer Organization, my heartfelt society seeks to broaden its international partnership. And I will end with this very nice quote saying the only thing that will redeem mankind is cooperation. So we strongly believe in cooperation, and we do hope that we are going to stay in touch and see you at the next summit on China, Europe, Latin America, and beyond that. So thank you very much for your kind attention, and looking forward to the discussions with you.
Thank you, Professor Deji, for your interesting lecture and sharing the ECO information, networks, challenges, and the missions with us. Thank you for emphasizing the care for quality of life and the survival of cancer patients. It is good to know that EU has some serious plans to beat cancer. The next speaker is myself. And I found it's very difficult to introduce myself, but I'm a professor at the Karolinska Institute, Stockholm, Sweden. I'm a member of Chinese Academy of Engineering, Academia Europa, European Academy of Sciences and Arts, National Academy of Inventors, US. So I'm doing a more basic research in cancer. I would like to share my slides. Let's see. How do I do this? Yeah, so today I'm going to present a new concept or paradigm for treatment of cancer by altering global adipose metabolism. If you look, the cancer drugs nowadays in the clinic for treatments of various cancers is basically can be divided into three categories. The first one is the red color that mainly targets the cancer cells. So this we call it a targeted therapy. There is a problem with this kind of drugs because the cancer cells usually have unstable genomes and they mutate all the time of their genes. They create the heterogeneous cell populations. So one kind of drug usually encounters resistance problem. The second class of drug is targets the other type of cells, non-cancer cells. We call the stromal cells in the cancer tissue, including anti-angiogenic drugs and immunotherapy is based on this kind of a principle to modulate immune cell functions and probably anti-inflammation and so on. But these drugs seems to be more welcome and effective. It can target basically many different type of cancers. For example, anti-angiogenic drugs and immunosuppressive drugs usually can treat the broad spectrum of cancers. The third category is the conventional therapy, including chemotherapy, radiation therapy that targets both cancer cells and proliferating mainly the cancer stromal cells. So now I'm going to speak about the other class of drug. Is a target is located outside the cancer itself. That would fit very well with the integrative oncology, because these drugs through modulates the global function of a cancer host and for treatment of cancer. So this is emerging a new type of therapy, especially given the facts that many cancer patients die of systemic disease, like cancer cachexia and the perineoplastic syndrome. There are no effective drugs available for this kind of treatments. So what I'm going to tell you is about how fat tissue, when you modulate fat tissue metabolism, you can develop effective therapy for treatment of cancer. So the three type of fat tissues in our body, the well-known white fat. White fat tissue is usually is in inner organ, as called real white fat. It's a function to store excessive energy. So when you eat, take up a lot of energy, you cannot spend all this energy, will be stored in adipocytes, white adipocytes. There's another type of fats called the brown adipose tissue, BAT. It's a function to spend energy, okay? So by producing heat, it burns excessive energy. Under certain circumstances, for example, cold exposure, when environmental temperatures are lower, the body had to heat up to maintain the core body temperature. Activation of brown fat is one of the key processes to achieve this goal. The other one is in between white fat and the brown fat, called the browning white fat. If needed, this white adipose tissue can undergo phenotypical and functional transition, moving towards the brownish type of function. So this diagram to show you on the cold exposure, the subcutaneous white fat become more brownish, and the brown adipose tissue become more activated by overexpressing one of the key mitochondria in the membrane protein called uncoupling protein 1, UCP1. So this protein is responsible for producing heat. Heat production in the adipose, in the activated adipose tissue, I usually call this thermogenic adipose tissue, is dependent on glucose uptake. Okay. So interestingly, cancer cells, when they divide, when they grow, and metastasis, also dependent on glucose to produce energy. This is called the glycolysis process, or Warburg effect, using anaerobic metabolic pathway to produce energy. So we ask a question, so what happens if we activate brown fat? What happens to tumors? So we did very simple experiments by placing the tumor-bearing animals, in this case, mice, experimental mice, with a different type of tumors in different temperature, in 4-degree, 30-degree, warmer temperature, colder temperature, to see what happens to the tumor growth. Because in the cold, during cold exposure, the brown fat becomes activated. As you can see that different tumors in a cold environment, they grow much slower, especially for those tumors clinically very difficult to treat. We call the hard to treat type of cancers, including pancreatic cancer and liver cancer, as you already heard. Simply cold exposure can reach more than 80% tumor suppression. This is much better than any of the known drugs to treat these kind of cancers. As you can appreciate in these slides, cold exposure significantly slowed down cancer cell proliferation. There is a specific marker, KICD7, to monitor cell proliferation. And also, you already heard from the previous two speakers, survival is a key. When you assess any cancer drug have any effects, you are not looking at the drug effects on tumor size, but you are much care about the drug effects on survival improvement. As you can see, in a cold environment, so tumor-bearing mice actually live almost double, long as the control group. Different models, the spontaneous model, we also see exactly same thing. This is a breast cancer model. In the colorectal cancer spontaneous mouse model, we see exactly same thing. This is an interesting slide to show you that under cold acclimation for experimental tumor-bearing mice, the glucose, this is a PET-CT imaging to monitor the glucose distribution. Usually in the clinic, they use this technology to find the tumors, cancers. In this case, as you can see, on the warm temperature, the glucose mainly taken up by the tumor tissue. On the cold, in the cold environment, the glucose redistributed, taken up by the brown fat and very little by the tumor tissue. So this really provides a evidence that activation brown fat would suppress tumor glucose uptake. As you can appreciate in this slide, that's cold exposure significantly lower the glucose, blood glucose level. If you do operation, simply remove brown fat in tumor-bearing mice, you basically completely neutralize the anti-tumor effect by cold. Same is true if you delete the UCP1 gene, the gene is responsible for heat production, the anti-tumor effect is completely ablated. This is clinically relevant. So this is experiments done by using human volunteers, did experiments on the 16-degree exposure. This is a tolerable cold exposure. I consider this as a Swedish summertime because I'm working in Sweden. It's a very cold country. You all know that 16 degree is much more tolerable. Actually, last week I swimmed, was 16 degree in the water. I was remember this results to show that 16 degrees is able to activate brown fat. So if you have a chance, you can do experiment on yourself. It's very pleasant as well, can make you become thinner as well, more fit. This is a cancer patient, lymphoma cancer patients exposed to the very mild cold environment. As you can appreciate, her brown fat became also, activated and increasing brown fat activation. And by contrast, the tumor tissue glucose uptake is completely neutralized. If you do not like cold exposure, so you would ask a question whether there is any drug that can replace cold to do exactly same job. The answer is yes. So there is a clinically available drug approved by FDA for treatments of bladder disease, overactive bladder. This drug called background is beta-3 adrenergic receptor agonists. But this drug can also activate brown fat, do exactly same thing as cold exposure, we treated tumor-bearing mice with this drug, clinically, approved dose, both suppress the tumor growth and prolong the survival for experimental mice. As you can appreciate, this drug effectively activates brown fat and also the subcutaneous white fat, the glucose redistribution. So this may represents a completely new class of drug, anti-cancer drug, by activation of brown adipose tissue for treatment of cancer. So we have been working in our lab. I don't have time to share with you. That's by altering adipose metabolism for treatments of obesity and also obesity-related diabetes, inflammation, cancer, as one of the examples, and the cardiovascular disease. So these other people working in the lab, and my lab is also supported by ERC Advanced Grants and Novo Nordisk Advanced Grants and the Swedish Research Council, Swedish Cancer Foundation, and so on. So I thank you for your attention. I stop sharing, so I should continue to chair sections. Yes, so we now move to a panel discussion section. So I like to extend our deepest gratitude to all distinguished speakers, participants for their contribution to this important summit, and especially for the speakers in each of the talks was not only demonstrating the importance of collaboration for treatment of cancer, but incredibly informative and offers valuable insights from different regions of around the globe. So by now, I had to look my WeChat. We have how many people? Is anybody can tell me this? I'm going to look. How many people have been online? So we have, I got the number now, let's see. So we have actually more than 10 million people have joined today's conference. So this is a more than the entire Swedish population. I'm extremely impressed. I never talked to so many people, but right now, the total participant number have exceeded more than 10 million online views. We are inspired. We have learned the knowledge from the speakers. We now move to the next exciting phase of the summit, the panel discussion. This section basically have, allow us to change the ideas, to look for, potential collaborations. And I think this is one of the key purposes of this meeting, is to find a interactive niches for collaboration. So I think I start maybe with a question to Professor Fan.
Yeah.
So you mentioned about the Chinese traditional medicine, yes. So I wonder, what do you think about the Chinese medicine in integrative oncology? So what is your view on this? You give a few examples, malaria and leukemia. What about the solid tumors?
Okay, this is a very, very good question. So, roughly to say in China, we have at least three kind of medical system. Of course, firstly is the Western medicine. The second is Chinese traditional medicine. I think the third is integrated both. That means Chinese medicine and Chinese traditional medicine and the Western medicine. That means integrated the medicine. So because the cancer is it's a very difficult problem to overcome. So so the two different systems, maybe the concept or methodology to management of a cancer is different. For example, the Western medicine is mainly focused on the kill the cancer cells. Yeah, to explore the many methodology, including the medicine to how to kill the cancer cell. But in Chinese traditional medicine, the main the focus on the emphasize to protection the or enhance the protection and the natural the force from the human body. So about 200 years ago, before the Western medicine introduced to China, it can last in several thousand years. So we just use the Chinese traditional medicine to treat the cancer. Also with encouraging result, just I told you in APL, we use the arsenic trioxide to treat the acute primary lymphocytic leukemia with the great effect. And now this drug has been used in the globally with a very good result. Now, another example is antimethylene. It is extracted from one kind of a plant. It can be used to treat malaria very effectively. The research to UU2 has won the Nobel Prize. So now we have also used this antimethylene, and we have found to not just reverse the bacterial drug resistance, but also can overcome the tumor, the multiple drug resistance, and so on. So I think it's a very it's a good opportunity for us to explore the anti-tumor drugs from the Chinese traditional medicine. I think it's because both systems are the different, including the concept or also methodology. So bothly, so we should use that integrate as an integrative the way. So why we in the integrative oncology, everybody knows that, including the Western country, why we add the holistic before the integrative oncology. That is where the holistic means at least two concepts. One is the whole body. I mean, we consider the human body as a view. It's also we integrated the human body to the environment, the different environment. The second concept is we should consider in all the factors involved, the tumor management. That means from the whole body, from the head to to food. And from all the factors, that means that we should consider that from the birth to days, from the structure and the function, from the medical and from clinical medicine and prevention, and also from the medical and the psychological were also the expert and the sport, and also we also considered all factors which involved in the prevention, screening, diagnosis, treatment, rehabilitation, and so on. So that is we integrated the concept of Chinese traditional medicine and the Western medicine together, so make it a better result. As you know, in for the many some kind of the common cancer in China, for example, lung cancer, liver cancer, esophageal cancer, stomach cancer, the 5-year survival rate is less than 20%. So in the Western country, including Europe and the USA and so on. So it's also the 5-year survival rate is not so high. It's almost 20%. How to solve the rest 80% of patients, the problem from patients? That is our the target in the future. That need our collaboration to solve this problem. So you know, we have so many methods and the technique and also the drugs, but all of them together, we can solve the 20% of patients. So in the future, the most importantly is no matter the new technique or new medicine, so we should use that to solve the problem from 80% of patients, but not just use in the 20%. We can use other methodology to solve. So that is, we think the Chinese traditional is candidate for that. So Chinese traditional medicine, it's complementary for the Western medicine. Combining Western integrative Western and Chinese medicine, so maybe we can form the new medical system that is a holistic integrative medicine. So thank you very much.
Thank you very much for this comprehensive answer. And I should see that all public audience, you have a right to ask questions. In Zoom, there is a function called Q&A. If you have any questions, you can post your question by opening that function. So I already get a question, but I will move to the second question to Professor Deji. So you know, there is a culture, difference between China and Europe, and that's also affect the family as well. So family care plays a major role, I guess, in China, and also in some countries, in European countries as well. So what do you think are the impacts of family care on cancer patient quality and their survival?
Professor Chow, thank you very much. It's not an easy question to answer, but I am not I am not in the worst situation. As you mentioned in the introduction, I am coming from Romania. So I started my career in psycho-oncology
Yeah.
doing research on cancer diagnosis non-disclosure. Like 20 years ago in Romania, it was quite the usual thing that not the cancer patient, but the family member was informed about the cancer diagnosis first. And some cancer patients were not informed personally. My father was battling a lung cancer, and this topic of how to communicate about cancer in family was the beginning of my career. I started doing research, and I wanted to understand if my experience, our experience as a family, makes any sense in the bigger picture. If others are having the same issues or not. And I was feeling very strange at that time because in psycho-oncology, the topic of cancer diagnosis non-disclosure seemed to be a topic that was already discussed in the 60s.
Mm.
And I said, there is no future here for me as a researcher because my topic of interest, it's outdated, at least in some continents. And then uh, I started to do a nationwide research and started to understand how sensitive uh, the and how complicated it is that actually cancer, it's not something that you do it alone. Cancer is something that affects everyone. I mean everyone. Family, the hospital doctors, the caregivers, the community you are living in. And of course, I thought, well, I have my publications and a much better understanding of the situation. And I was looking for new topics to understand and maybe new topics that were emerging in psycho-oncology. And then something strange happened. Uh, I started following um, the citations of my articles on cancer diagnosis non-disclosure. And soon I discovered that the most cited papers of mine are those that are related to cancer diagnosis non-disclosure. And soon I understood how big this question is in many parts of the world. And it's still a question in some parts of uh, America, USA, and in some parts of Europe. And that was the moment when I understood that in many Asian countries and in many Arabic countries,
No.
the kind of questions that I tried to answer are real life questions. And so I was so happy to discover this. Maybe my research, after all, was meant to discover that there is a bigger world outside. And then the meaning of our research and our work comes actually from the cultures and the places that we live and understand how they are. I just shared with you this because your question is very much a reflection on this. Because in all these years that I have been working in Brussels and international societies, we came to understand from a research and policy point of view that family caregivers have the same psychosocial burden as the patients. And sometimes they are in much less good health, mental health, than the patients themselves. So I have to tell you that although my journey started in a very family-oriented cancer care practice, I came to understand that this is a very meaningful question, and caring for a family member is something that is based on the communication that we have with the family member. A good communication a family-focused communication. It's very, very much cherished because sometimes what happens is that families try to treat the family member, mother, father, son, brothers, like a patient. But they are our family members, you know. You cannot treat family members as patients at home because this is not the hospital. So, and in the last years here in Brussels as well, together with other societies, we have tried to move the agenda of cancer caregivers very much to the front because a family-focused cancer care, it's really a quality cancer care in many, many, many cases. Simply because the so-called informal caregivers, I mean, this is how we call them, but they are actually our family members. They are really the persons who are there from the beginning until, you know, whatever happens, survival or maybe palliative care. So it has been a journey for me to start with the culture of an Eastern European country and to understand, you know, that in Romania and in Eastern Europe, family is also a very core value of every day. And of course, especially when there is a crisis like cancer.
Yeah.
So I don't want to take too much time because my presentation was longer than expected. So in short, Professor Gao, this is my answer from my career and my experience.
Yeah. So what is your, just follow up a very short question. What is your advice if you disclose the cancer disease to the affected individuals? You would psychologically affect the cancer patients. You also affect the family members. If you do not disclose this information to the patients, but only to family members, at least you reduce one psychology burden to the patients. So what is your advice, the balance for this? Is any studies to show whether this information should be shared by patients or should be remain undisclosed?
Professor Gao, you didn't make my life easier. It even I will try to answer very shortly. So I think two things are very important. Cancer cannot be a lived experience without family members. If there is a family around, you cannot shut out family members. Don't try to do that. That's the first one. And the second one is you need to involve and you need to collaborate with family members. Don't pretend that as a healthcare service provider, you know much more about your patient's family life than the family members. Ask the family members. Try to understand what would be the impact of sharing the news. Because let me tell you, and probably you all know because we are doctors and professors, we all know from our clinical practice that cancer, it's not a one time breaking bad news. You don't have to break bad news once if there is a cancer. No, you have to have difficult conversations many times. Cancer is really a journey. And I have to tell you that maybe the toughest part, it's not the cancer diagnosis communication, although it is a big crisis, but sometimes the prognosis, and talking about prognosis can be really, really complicated. So in short, this would be what I would very much appreciate if clinicians and professionals working with people affected by cancer could understand, because the family is a resource and uh, it's actually a shared decision making. This is what I believe in.
Yeah, Thank you very much. And I saw a question for me from the public, audience. I may read the question. This is an anonymous person that's asked a question. Dear Professor Cao, how close are we to translate the concept of activating thermogenic adipose tissue into clinical practice? My answer is, yes, we are doing clinical trials right now in patients. And we already see some, promising, very early findings in the pilot studies. I think it's a clinical relevance. So I can tell you, our study discovery is a clinical relevance. So I welcome all. We still have time. Welcome the audience to raise any questions, any issues, if you want to ask. Okay, let's see any you must move. Okay, so any questions from audience? Let's see if I sometimes my network may not work. So if there's no further questions, we may have to summarize today's meeting. Let me look at this. So I want to particularly thank all the panelists, the audience, for today's very, very productive and insightful discussions. And our conversations not only very engaging, but also I think we share the most updated knowledge from cancer care, medication, and the research. I hope that this will provide the basis for further interactions between the Chinese oncologists, cancer care professionals, with the European experts. At this time, I'm very pleased to announce we have actually attracted more than 15 million of people online by now at the time of this speaking. A lot of people actually viewed this summit. Is extremely successful. I even feel very proud of myself to be part of this. As we draw this summit to the end, I feel with a profound sense of gratitude and optimistic attitudes. It has been extraordinary journey of learning, sharing, and especially for future paving the pathway for future collaborations. I'm sure we will have more this type of collaborative, this kind of joint meetings around the globe. So we appreciate all the participants. Special thanks to distinguished speakers from both regions. You have preserved any attitude. You're very open to share the knowledge, the thoughts with us, with all audience. We learned a lot. Personally, I learned a lot as well. I believe together we can keep the momentum continues with one purpose, that is joint efforts to combat cancer. We're getting closer there because I looked at the figures today, the numbers. Despite the fact that we have more cancer instances, but the survival, the good news is the survival, especially long-term survival. For example, European countries combined reach more than 35% of patients can have really very long-term survivals. So we can live with this disease. I believe that number will continue to be increased. And to reach that goal, we need to have joint efforts. We need to collaborate. So thank you once again for this wonderful meeting and for your time. I guess it's late in some parts of the globe. In China, it's late. Thank you very much for your valuable time. And we end up this meeting. If anybody have questions, you can contact all experts and also conference the responsible people. I guess you have their email address. So thank you. We close the meeting now. Thank you very much.
Thank you.
Bye. Thank you very much.